Hello, and welcome to our little series on psychological assessment. Today's topic is one of the most clinical in the entire series, that being the mental status examination. And without further ado, here we go. All right. So mental status exam, or MSE for short, is an important set of procedures used in the course of many clinical assessments. So you can sort of begin to understand the MSE when you compare it with what happens in the interview. When I interview you, you tell me about your experiences, your subjective take on your own experience. If this was in a medical context, these experiences are referred to as symptoms, of course. The MSE, by contrast, consists of my observations of you. I'm putting objective in quotes with a question, parentheses with a question mark there, because, of course, really it's my subjective take on you, but it's objective in the sense that it's an outside perspective on you. It's something that can be witnessed by others. Again, when you're being seen by a medical practitioner, what they observe would be referred to as signs of illness. If I report to you, my doctor, that my knee hurts, the pain is a symptom. If upon examining my knee, you find that there is heat in a certain part of it, which might suggest friction of bone against bone, the heat is a sign, you see. And in order to make a proper diagnosis, one tries to put the two together, the subjective complaint with the more objective observation. Now, the MSE, strictly speaking, has two very different components or aspects to it. On the one hand, there's what I'm going to call the informal mental status exam. And that really comprises every observation you make about a person with whom you're meeting. The other component, which is going to occupy much more of our time today, is what I'm calling the formal MSE, which is actually a kind of cognitive assessment. And again, to draw the analogy out a bit further with being seen by an ordinary physician, as opposed to a specialist in psychiatry or a non-medical mental health practitioner, the physician does interview you, ask you what's wrong, take a history of your illness, maybe a bit of a background history, especially about medical issues. But the physician also engages in a more or less systematic examination, including semi-standardized procedures like listening to your pulse with a stethoscope, listening to gastric motility, looking in your eyes and, with the, what is it called? The thing that looks in your eye. I know that where your ears and your nose with an otolaryngoscope, ophthalmoscope, that's the word I was looking for, checking your knee reflexes with a patellar hammer and so forth and so on. In the mental health world, we do have something analogous to that, without all the little hammers and inflatables and lights being shone, because we're looking not at physical phenomena, but at mental ones. So we'll spend a few minutes on the informal aspect of the MSE. Now, again, this is something that you're always doing, whether you call it an MSE or not. You're meeting with a client, a patient, you're looking and you're listening, not only to the surface meaning of what they say, but also to all the other messages and signals you're receiving. How do they look coming in the room? Do they look roughly the age that they report themselves to be, somewhat older or younger? Are they, how is their grooming? Are they disheveled? Are they dressed to the nines? Are they neat but casual? Where do they fall on this kind of continuum? You look at how they walk. Look at how they move when they sit down. Is there a fluidity to the movement, or is there a certain stiffness? Are there peculiar physical mannerisms, tremors, or whatnot? If you happen to shake hands, does the grip have a nice firm quality to it? You definitely listen to their speech, not only the specific words, but how quickly do they speak? How loudly, or softly do they speak? How much do they have to say? What kind of vocabulary do they seem to be expressing? You try to listen to how their thought processes work. Is the thinking pretty much logical and goal-directed, getting you from here to there? Does it tend to spin off? get all circumstantial or even get lost on a tangent? Is there anything truly bizarre about their thinking? And you look for expression of affect, of emotion, right? Or do they exhibit a full range of affect that's appropriate to the context? Is their affect a little bit constricted? Are there certain emotions they seem to be less able to express? Or is all of the affective display somewhat blunted or even wholly flat? And, how do they treat you? Are they basically cooperative? Is there a certain guardedness about them? Are they outright belligerent, or are they treating you in some other way? Are they being seductive? Are they being very helpless seeming? What's the interpersonal message you're getting here? And really anything else that you happen to find noteworthy. But it is important to remember, even when you have things that are falling, quote unquote, within normal limits, it still should be reported, because someone reading your report wasn't there and doesn't know. So the fact that they came in, reasonably well groomed, neatly but casually dressed, the fact they spoke at a fairly typical rate and a fairly typical volume, the fact that their thinking was basically logical and goal-directed, that they exhibited a full range of affect, all these things should be reported. Because if you don't report it, again, there's the possibility that it wasn't that way, and the next person down the road to be meeting with the patient won't know what they were like when they saw you. Now that's very quick overview of the informal aspect of the MSE. You can find vocabulary lists of the kinds of terms that get used in various sites online, actually, at this point. Some clinics actually have checklists. So, affect, and you check off, full range or constricted or whatever. Kind of a depressing reality, but there it is. What we're really going to dig into for the rest of our time, though, is the formal mental status examination, formal MSE. And I want to say that in some clinical assessments, this is really, really important. If you happen to be a medically trained practitioner, a psychiatrist, a neurologist, probably a psychiatric nurse practitioner, this is likely to be something that you rely very heavily on, that you consider to be a centerpiece of your assessment work, your clinical assessment work. If you're a non-medical practitioner, clinical psychologist by training, such as myself, or a mental health counselor at a master's level, or someone else, we use it less regularly, less routinely. It's more likely to be used if we believe that there are questions that we need to answer here. And what that kind of boils down to is that when your average outpatient who called and made an appointment shows up for the appointment, comes walking into your office, they look fine, they speak coherently, they have, relatively, I guess I want to say standard issue concerns about things like depression or their work performance or anxiety, or their romantic entanglements. You usually aren't going to get that much out of a mental status exam to justify spending a lot of time on it. But the more likely you think it is that there could be some more severe form of psychopathology present, or a neurological problem, a neurodevelopmental problem, the importance of the MSE grows exponentially. So the procedures, what are we going to do? What you typically are going to do is kind of start at the bottom with the most basic cognitive functions and work your way up, because the higher you go, in sort of a hierarchy of cognitive functions, well, the more dependent they are on the ones that are below them. So if you can't do really basic stuff, you're probably not going to be able to do higher level stuff. And in some cases, you may just discontinue the examination, having ascertained that the person really is unable to work above a certain level. Now, ideally, you're doing a pretty comprehensive assessment here, real overview of multiple cognitive functions. The trouble is, to do that right, you are probably going to be spending 20 or 30 minutes anyway on just the mental status examination, possibly even longer, and you don't always have that available. So in practice, even when it's being done by medical practitioners, almost want to say especially then, it's not quite fair. The time constraints that are in place mean that it's going to be done quickly, and maybe only a very few procedures will be done, and they may even be cursory, where instead of, say asking a series of 5 questions, you only ask 2, and bail at that point, because you need to get to the next piece of your assessment that all has to happen in a very narrow time frame. Again, begin at the basic levels and proceed upward systematically as you go. Now, again, in many cases, you may be able to assume that some of the really basic things are intact and skip over a couple of these procedures, including some that I'm not even discussing today, because I'm more concerned with its use in psychiatry than its use in neurology. So, real basic, right? Are they awake and alert? Again, a lot of the times it's just, yeah, they are, they come walking in, and, their eyes are open and they respond to you, and that's that. But you do encounter clients who are somewhat drowsy. I could be lapsing that way at this time of the afternoon, or more seriously, stuporous or even comatose. Or at the other extreme, you get people who are agitated and can't focus for the opposite reason. They're just too wound up with pacing about and spewing agitated speech. Okay, there you can observe this, and to some extent you get what you need, or you can do a formal assessment. The instrument that's most widely used here is something known as the Glasgow Coma Scale, which has been around now for close to 50 years as I record this, and I'll show you the elements of it just quickly. There are 3 elements. 2 are on this slide, 1 on the next. The first is eye opening. So, if their eyes are open and they're blinking, more way one does, they have 4 points without you doing anything. But if the eyes are closed, then if you say, hey, Steve, and I open my eyes and I'm there, hey, I got 3 points, right? And you work your way down from there. Verbal response, again, if I'm speaking to you in a more or less coherent way, replying to your questions in a meaningful way, I have 5 points. But you work your way down from there. Notice at the lowest level for each of these, you have 1 point, so there isn't a 0 option. Third thing you look at is what's called motor response, movement. And here you are doing a little bit of a formal test. So, you might tell somebody, point at the ceiling, that sort of thing, or take this piece of paper, fold it in half and put it on the floor. And if they can do follow simple commands, they get all 6 points. If they can't seem to do that, but they do at least make some meaningful movement when you poke them with something. This is very doctorly stuff, right? So you poke them with something and they move, go to move it away, they get 5 points. You poke them and all that happens is they pull away, they get 4, so on down. So in toto, you could have a score anywhere from 3 to 15 on this. You're considered to be in a coma if you score like 3 or very close to it, right? Your eyes are shut and stay shut. You do not provide any verbal responses, even garbled ones, and you're unable to follow commands. And then there's a sort of rating system such that scores, up to about 8 are thought likely to reflect relatively severe injuries. So if a person, is scoring 5 or 6 on the Glasgow, they probably took a nasty, nasty hit to the brain in that automobile accident. 9 to 12, moderate. 13 to 15, it's pretty mild because they're actually doing just about everything. Do always remember that if the level of consciousness fluctuates, so they go from a stuporous or even potentially comatose level all the way up to agitated, back down into a stupor, and sometimes perfectly clear for a little while, that's a hallmark of delirium, which is a medical emergency. You get medical backup right away if there are patients in a delirium. Now, one rung up, so to speak, is orientation. And if you work in clinical settings, you'll sometimes see this cryptic little entry in charts, 0x3, or 0, the X is for times, right? And actually it's not a 0, it's an O times 3. Oriented to 3 spheres would be the way it would be written out, which sounds like it's going to be something just amazingly, cognitive sciencey or doctorly. It's actually pretty straightforward, though. Person, place, time. Those are the 3 spheres. Do you know who you are? Your name, your age, etc. Do you know where you are? What town or city, the building you're in, etc. And do you know when it is? What's, the date, preferably, or at least the day of the week, along with the month and the year. That's it. If you know all those things, you are oriented to 3 spheres. Now, sometimes you also find they add the time of day as another one. If you're going to do time of day, I should warn you, make sure if they're looking out the window to try to figure it out, that you make a note of that. Likewise, if they can't give you the week or the month and you ask for the season to see if they have some vague idea when it is, see if they're looking out the window to, like, are there leaves on the trees kind of a look, because that's a sign that they don't know, but they're trying to cover it up. Now, disorientation you'll find in a delirium, of course. Also in dementias, you'll find some degree of disorientation, typically not knowing when it is and often not where they are. Also, of course, transient global amnesia. And sometimes if a person is badly disorganized in a psychotic episode or in a very severely dissociative state, also they will be showing the disorientation. Then there's vigilance. Essentially, can I stay on track? Can I stay tuned in? Clearly, this is important, right? I mean, if people are unable to do these basic tasks, you're not going to get very far with them in a diagnostic interview, a psychotherapy session, or anything else, right? A common procedure to evaluate vigilance, if you're going to do it, is to tell the person you're working with, listen closely. I'm going to read a list of letters, and whenever I say the letter, let's say A, I want you to tap, and you proceed. So you have a list of like 50, 60, 100 letters, and supposedly random, and you are going through it, and every time you randomly say A or whatever letter you've picked, they're supposed to tap. Generally speaking, people who are cognitively intact aren't going to miss any. Maybe one if it's a long series, but you should be able to notice, oh, they just said A again, tap, there we go. Now things are going to start to get more challenging for ordinary people, because the procedures from here on up are going to often include different levels of difficulty. So you'll have easier, more medium level, and then more intense. Concentration is often assessed by actually a very challenging task, or at least many people find it so. It's known as serial sevens. So your clinician is sitting there with you or standing there and says, listen, I'd like you to count backwards from 100 by sevens. And the idea, of course, is you're going to count by 7. So 100, 93, 86, 79, 72, 65, and so forth. You stop them 5, 6, maybe 8 subtractions. If they get that far, you stop them. It's like, thank you very much. And you know that they concentrated pretty well. And if you're doing a actual scoring on this, each subtraction that's correct gets them a point. Incidentally, if I did 100, 93, 87, 80, I did make a mistake, from 93, I didn't get to 86, I got to 87. So I don't get that point, but I do get the point for going correctly from 87 to 80. I did subtract 7 that time. Now, there are alternatives. Serial sevens is tough, and you do get pushback to this one from patients, for real. There are alternatives, but they're not precise alternatives because they're each a bit easier. One common one is to do what's called serial threes, 100, 97, 94, 91, see how they do with that. Another is to spell the word world backwards. So you have them spell world first, just make sure they know how to spell the word world, and then you say, I want you to spell it backwards. Now, there also are tasks that tap into both attention and concentration, the way the vigilance and serial sevens procedures do, and also tap into short-term or working memory. The best known of these is known as digit repetition. So standard procedure here, you definitely do what's called digits forward. I'm going to say some numbers. Listen closely. For when I'm done, I want you to repeat them back in the same order. And so I might begin with 8, 1, 9. pause, and you're supposed to say 819, and I write 819 down. If you get it, I proceed to read you a list of 4 digits, and you're supposed to get 4 back. You succeed, I try 5, then 6, then 7. If you fail one, I do give you typically another try at the same level. So if you missed one at, say, 6, I'll give you another 6, and you made it. Okay, we'll proceed. I proceed to 7. We don't say anything about what we're doing. Just keep going. When they fail both at twice at a certain level, you've reached their ceiling, so to speak, what used to be called the span of apprehension. That's their maximum score. A healthy young adult, very typically around 7 or 8 forward is pretty common. 6, a little worrisome if they're a young adult. 8 or 9 or 10, and you're like, wow, that's amazing. And you generally stop after 9 or 10, by the way, because they've done it. They're fine. The second procedure, which isn't always included, but should be, is called digits backward. Exactly what you're guessing. I'm going to say some more numbers. This time when I'm through, I'd like you to repeat them in reverse order, backwards. For example, if I say 4, 8, what would you say? And if they do that right, then you begin for real. If they don't, you remind them, let them know, no, it would be 8, 4. And then you start. You do start at 2 and keep working your way up, just like you did with digits forward. And what you typically are going to find, this is a harder task, right? You have to hold them in your working memory. And while they're there, you have to okay, I'm going to go to the last one and, get that one, and he'll keep the rest. And I got to go to the second to last. And, it's putting a little more strain on the system. So typical average is that you get about 1 less backwards than forwards. Sometimes they're the same. Sometimes it's 2 less, but on average, 1 less. A lot less suggests a real problem with the more active components of working memory. If I can do 7 forward, but only 3 backward, that's a little more ominous. Now, at this point, you're all, going like, oh my gosh, it's all like numbers and deep concentration. Here's a very different kind of task, which isn't always included, but again, perhaps should be. It's called verbal fluency. It's a very specific function, verbal fluency. It is a prefrontal function. It doesn't correlate that strongly with a lot of other mental abilities, but it is a pretty good indicator of the health of at least some portion of the prefrontal cortex. Very common procedures here are what is known as the FAS procedure or test, and categories, which is usually animals. The FAS works like this. I say to you, I'd like you, when I say go, to say as many words as you can think of that begin with the letter F. Keep going till I say stop. And you give them 60 seconds. You got to have your little stopwatch or your phone on you with the stopwatch app open, and they start, and you're jotting down everything they're saying, because there's interesting information in the selection they make. When they reach 60 seconds, stop. You do the same with the letter A and the same with the letter S. So you have a kind of a stable measurement of their fluency across these 3 initial letters. Incidentally, A is there aren't as many of those. They're a little harder to come up with, so you tend to get fewer there than for F or S. The other procedure that can be used would involve naming a category and asking them to say as many words as they can that represent members of the category. Most often we use animals because most people actually do know the names of a lot of animals. And so you say, I'd like to name as many animals as you can in the next minute. Ready, go. I'm emphasizing here because I've had students, including people who are graduate students, who somehow don't realize this. Animal is a broad category. It's not just mammals. It includes birds and reptiles and fish and insects and clams, and anything else that is an animal. Generally speaking, if you do both of these procedures, you're going to find that people get about twice as many words in a category as they do on average with the purely phonetic clue, the opening letter. Yeah, so that was at least different, although still the person's working away, aren't they? Now, learning and memory, hugely important. Of course, we already began to look at memory, at least short-term or working memory, with the digit span task. But now we're moving on to actual acquisition of new knowledge, things that are being moved from that very brief, place we call short-term or working memory into something more durable. And well, we want to study this because this is vitally important in life and not infrequently impaired in the aftermath of a head injury, in the context of course, of a dementia, or some psychiatric or mild neurodevelopmental disorders can also show some degree of problem with memory formation or learning. The thing you have to remember here is that short-term memories, if you don't keep rehearsing them, they're gone fast. As soon as you're thinking about something else, within a minute or so, it's pretty much gone. So when we say learning, we mean you got it in well enough that it survives. So that even if I come back 5 or 10 or 15 minutes later, if it's still there and you haven't been able to spend the whole time just looping it, rehearsing it, you did learn it. You did learn it. Now, there's also something known as remote memory, which is memory for things long, long ago. That is also relevant, though we're going to do less with it today. Clinically, obviously, dementias, especially if the Alzheimer's type, and amnestic disorders, so-called, are associated with really, really severe impairment of memory formation, while remote memory tends to be relatively spared. So if you ask about things from long ago, the person can still answer meaningfully, but things that happened 10 minutes ago, no. One problem with assessing remote memory, by the way, is you often don't know what the right answer is. So if you ask me what elementary school I went to and I name one, what if I'm just making it up? You don't know unless you have an informant. But you try. If a person doesn't know, often they're going to say, I don't know. So there are a few procedures that can be used for assessing learning and memory. One pretty common one, particularly if you're conducting an evaluation for possible dementia, is to have a very short list of words, like 3 words, maybe 4 or 5 words. And instruct you, listen carefully. I'm going to name a few things, and I want you to be able to repeat them back to me. You say your 3 words, ask them what they were. And so say they get all 3, they'd a little note, you remembered 3 out of 3 objects, immediately. And then we say, now remember those. I'm going to ask for them again a little later. And you do some other procedures to make sure that the short-term or working memory is gone. And then you say, remember, I asked you to remember a few words for me before. What were those words again? And see if they can still get 3 out of 3, or if they only get 2 out of 3, or if they say, oh, I don't know any of them. One variant on this is that you might choose to repeat the words a second time. So after they've said them, especially if they didn't get them all immediately, say, no, remember now, they are do, 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 remember that. Another variant, which is, I think, very clever, is for you as the examiner to show them objects. So like, what's this I'm holding here? They say it's a pen. Say, good, that's a pen, and you kind of bring your different objects out and have them all there. So it's stuff you got in your pockets, right? It'll be like a coin, a key, a pen, knife, whatever you carry around, a phone, but just a few of these things. And then you say, okay, so it's a pen, a quarter, and a key. Okay, can you remember that? I'm going to put them away now. Now, what were those 3 things? Now, and then of course, again, tell them to remember later on. The extra mileage you get out of this is that you also find out whether they can actually recognize and name things, which is pretty basic. But again, in neurological settings, sometimes even such basic things as knowing what I'm looking at, or being able to name a common object like a coin or a key becomes impaired. Okay. Generally speaking, intact adults are going to make no errors. Maybe they won't remember one of them on delayed recall, but that's about it. So if you want something a little more challenging, something that's going to give you more differentiated results, you could use what's known as story recall. And here, I would simply tell you, listen, I'm going to tell you a very short story, and I want you to listen closely and try to remember as much of it as you can, because I'm going to ask you to tell me the story back when I'm done. Okay, are you ready? Right. Stories are broken into so-called elements, units of story. Each of them represents a detail that's relevant to the story. Usually they've got about 24, 25, maybe 30 elements to them. And the score, quote unquote, is how many of those elements the person remembers. They are allowed to do a little bit of rephrasing, or to have things out of order. That doesn't mean they didn't remember it. It just means they're not a perfect storyteller in one try, but did they remember it? So, here's an example from newcomers Carson Jones stories. It's a 29 element story, the way I have it broken down. Lucy Carson, while visiting her brother in a small city in Virginia, got lost walking to the art museum. She searched her pockets for the directions that had been written for her. Unfortunately, she had left them sitting on her wooden dresser. She then asked a bus driver for directions. He said to walk north on 11th Avenue for 5 blocks. And can you say this back? You see how each element does contain a meaningful detail relevant to the story, right? So she asked for directions, that's 2 elements. The bus driver would be a 3rd one. He said to walk north for 5 blocks. You've got 4 elements, but you missed that it's an avenue and that it's actually 11th Avenue. When they've done this, and you've written down what they've said and you're ready to score it, you do again say, now try to remember that story, because I'm going to ask you for it again in a little while. And you see how much they still remember. No, people don't remember all of it, even immediately, even healthy young adults as a rule. You're going to miss some pieces here and there. There are other things you can do. Those are the 2 main ones, but not infrequently, someone may use what's called a supraspan word list. That's a list of, say, 15 or 16 words. It's too many to learn in one go. You can only get 7 or 8 typically in one go. That's the short-term memory ceiling you're running up against. So you actually read it, see how many they can remember in any order, read it again, see how many they remember, read it again, test recall, and you'll do typically 5 repetitions, sometimes perhaps just 4. And each time you're writing down what they say, and then of course at tallying them up. And what you're going to get is a learning curve, right? They're going to go from 0, up to say 7 or 8, and then very likely they're going to jump up to maybe from 7 to 10, and then maybe to 12 to 13 to 14. Diminishing returns kicking in as you go. You can do all kinds of things to jazz this procedure up. It's a phenomenally informative kind of neurocognitive test, actually. And again, you see how many they remember after the 5 learning trials, and you come back, with the delayed recall later and see how many they still have. Sometimes you'll also have it. This is one of the ways of jazzing it up. You have a second list of words, which is longer and includes all of the 15, say, from your original list. So after you test their delayed recall, 10 minutes, 15 minutes down the road, you say, now I'm going to read you another list of words. This time, I just want you to tell me whether it was or was not on the list that I read you before. So you're seeing, even if they can't summon it to mind, do they still spot it, recognize it when it's there in front of them? And yet another procedure is known as paired associates learning. 2 words to be associated with each other. So what I would say is I'm going to say some pairs of words, and what I want you to remember is the second word that goes with the first word. So I'd say stove, letter, cloud, bottle, and I would give you however many of those, 5, 6, 8 of those, and then coming around next time, you could go in any order on these. So I might say cloud, and you were supposed to say bottle. If you don't, I'll say, no, it was bottle. So you get another little learning trial. And again, if you have, say, 8 of these, you can do a few rounds to see if they can master it. If you do just, say, 4 of them, hopefully they can get it in 1 or 2 goes. That's all it is. It's a very different kind of procedure. The list learning, paired associates learning, story learning are all subtly different, but they're all tapping into the person's fundamental ability to form new long-term memories. And then there's spatial thinking, visuospatial thinking, right? We don't only think in words, in numbers, we also think in terms of where things are in space and how they're shaped. Now, this is often not included in MSEs, in part because you do actually need little props for this. Like everything we've done so far, you could either like make up as you went along if you've memorized the stuff, or just look at your little piece of paper and say it to them. Here, you're going to need at least like a blank sheet of paper and a pencil to give them. Not a lot to ask, in my opinion, but you do need that. Remember that language functions are primarily housed in what we call the dominant cerebral hemisphere, which for the large majority of us is the left cerebral hemisphere. Spatial thinking is not as clearly, cleanly lateralized as is language, but there's an awful lot of it that is housed in the non-dominant, for most of us, the right cerebral hemisphere. So if you neglect assessment of spatial tasks, you may miss out when there are selective lateralized lesions affecting only the non-dominant, typically right hemisphere. All right, so you really should have some kind of a spatial assessment in place. Now, you actually can design spatial tasks that measure working memory, that measure learning and memory, or fluency even. Those do exist, but they're virtually never used in an MSE. That would be a detailed, comprehensive neuropsychological assessment. So in practice, you're likely to do just one or two things. One procedure that might be tried is known as design copying. So, again, I give you paper, pencil on a clipboard or a desk, and I show you designs one at a time, typically simple ones, and say, I'd like you to make as good a copy of this as you can. And then I have some simple rating scale for, did you successfully represent the 3D cube or the intersecting polygons? Now, again, there are formal tests of this sort, which you can study, the Bender Gestalt, useful with children, the Ray Austerius complex figure, useful with adults. But in the MSE, it's likely to be a more stripped down procedure. And then there's what's called drawing to command. So you see the distinction. Design copying, it's like, here is something, copy it. Drawing to command, you don't have a model, you're being told simply to sketch it out. So again, you need the blank paper and the pencil, but here you don't have to have little designs to show them. You can just say, whatever. Sometimes they use something like, I'd like you to draw a picture of a daisy in a flower pot, or a house with two walls showing. Maybe you have them do a few things just on one page. We're not doing an art test here. One popular procedure worth a nod here is what's known as the clock drawing task. You instruct them to draw the face of a clock, put in all the numbers, and set the hands to the time you name. 10 past 11 is a popular choice here. This actually is a widely studied, long-enduring test, which can work on its own as a pretty good screening test for serious cognitive dysfunction, brain injury, dementia, and the like. In the example shown, for example, you may have noticed that the 10 past 11 was done incorrectly. The person made an outline, fine. They put in all the numbers in the correct order, more or less the correct positioning, doesn't have to be perfect. The 11 is correct. The slightly longer minute hand is correct, but it's in the wrong place. It's just after 11 because, 10 after 11 isn't all the way to an hour, is it? But of course, as you all probably remember, you would actually have the minute hand pointing over at the 2 because that's 10 minutes past the hour, and the numbers on the dial are only for the hours. Again, a fantastically interesting test, actually. Now we're getting into higher cognitive functions. So we've done things about all sorts of stuff, right? I mean, it was really an amazing assessment we're doing on the fly here. But we get to higher cognitive functions and typically start with what's referred to as fund of information. This is just how much general stuff you know about the world. Now, of everything in the mental status exam, this is the most dependent on your cultural background, including culture as in where you're from, also including culture as in the level of education you've attained, to what extent you seek out cultural experiences, read, view documentaries, etc. And so you have to keep the person's background carefully in mind when evaluating the results here. This is stuff that, you know it or you don't know it. And if you know it, you probably know it for a long time. Some things are harder to recall than others, but the knowledge is there. So this is what you sometimes see referred to as a crystallized mental ability. It isn't affected that much by normal aging, normal quote unquote aging. So it's very useful as a comparison point with other abilities that are more fluid, that require you to think on your feet more. If you find the crystallized is still pretty good, but the fluid is not, that's fairly strong evidence that some kind of a decline may be kicking in, or perhaps that the person has invested heavily in mastering rote knowledge. You do run into this, in earlier life as well. Some folks who are, very obsessional, or in some cases on the so-called autism spectrum, invest heavily in, I need a lot of factual knowledge, and they pile it on to the extent that exceeds their ability to reason with knowledge. Okay, so you could just ask about things like current and recent events. So, your examiner might say, I'd like you to name 4 people who've been president of the United States since 1960, or who's the president, who was president before him, who's the governor, who's the mayor of the city, kind of that sort of thing. That's pretty narrow, frankly, but it's often done. The other thing you can do is to have a set of questions, and you may have as many as 10 or 12 of these, or you may have only as few as 3, which are questions about, general stuff one might or might not know about the world, typically starting with relatively, I want to say easy, widely known things, and working your way up to ones that might be less so. So tell me, what does the heart do? Most people probably know what the heart does. Where is Argentina? Well, Argentina is a pretty important country, and a person might be able to come up with at least South America. Who wrote Othello? And now it's like, I think I learned that in high school once, right? Which is the largest planet in the solar system, and so forth. Then there's a little section, not always included, but most often it is, relating to judgment and insight. Judgment. Do you know what, do you understand the situation here? Do you know what's supposed to happen and why that's what's supposed to happen? If you do, you're much more likely to make effective decisions in life. Now, assessing judgment, typically they use a couple of questions that tap into whether you sort of understand the rules and the consequences of possible behavioral choices. Maybe, what should you do if you find someone's wallet, including their ID? You should make some attempt to contact them, or turn it in to the police, or put it in a mailbox. Even, the postal service will try to figure it out, I hope. You should not simply steal it or leave it there and think maybe they'll come back for it, etc. What should you do if you're in a busy restaurant and you're the first person to notice smoke and flames? More of an emergency situation. The answer, by the way, is not, the good answer is not holler far, because that's just going to create a panic, and that's not what you should do. So you should think, well, find someone like the maitre d' or the manager, and let them know that, hey, there seems to be a problem over there. There's a fire breaking out, right? Insight. We're assuming you're talking to a patient here. Something's wrong. That's why they're being evaluated. So what's your understanding of the problems you've been having? Do they understand that they have a certain kind of illness, for example, and have a good explanation for what that means, and so forth and so on, or not? We're almost there, by the way, because we're up to the highest level that's assessed here, which is abstract thinking. We have 2 procedures for this. The first is known as similarities. Now, think about abstract thinking. There's concrete, right? Solid, it's there, right? This is a fact. Jupiter is a big planet. Boom, right? You use a lever to pry something up. Fact. Then there's abstract, where you've taken experiences and derived more general principles from those. You've derived inferences from it. You've done work to organize your ideas more effectively. Similarities is a simple procedure in which you ask a person to tell you what two things have in common. So you say, I'm going to say two words. And what I'd like you to do is tell me the most important thing they have in common, the most important way in which they're alike, right? And so you could, and again, you do this in ascending order of difficulty. You may do as few as 2 or 3. You may do as many as 8 or 10, depending on the constraints of time. But you begin with something simple, like an apple and a banana. And a good answer would be fruit. Partial credit answers that suggest there's some ability to abstract, but it may not be ideal, might be things like, you eat them both. They have skins. They're brightly colored. Those are all true of apples and bananas, but they're not like the essential category one up from apple and banana. A painting and a song, more challenging, right? Because it's a little bit more of an abstract set of concepts, but they're both art forms or modes of creative expression. And you can get up to very challenging ones that sound like opposites, like praise and punishment. But a person who thinks it through will say, well, they both affect your behavior. They affect what you do next, or they're ways of trying to show people what you want them to do and not do. Fair enough. And lastly, and then we have just a couple of more things to look at, that short forms mainly. There's what's known as proverb interpretation. With this, and I have to say also the clock, I sometimes wonder, how long do these have left as people spend less time learning about analog clocks and really don't use proverbs as much as they used to. But the fact is, you really don't want people to have memorized the meanings of the proverbs anyway. You want them to be able to think through what it might mean. So proverbs, adages, maxims, called sayings, right? They have a literal meaning, but the literal meaning isn't the important thing. The important thing is the more general principle or rule about life that's being expressed by the saying. So you make sure your person knows what that is, that, it's a proverb, it's a saying, et cetera, and then you ask them to interpret some for you. There are lots of options here. One relatively simple, common one, don't count your chickens before they're hatched, right? One used very frequently by psychiatrists in mental status exams is, people who live in glass houses shouldn't throw stones. And then there's a million others. A stitch in time saves 9. One swallow does not a summer make, et cetera, et cetera. So people who live in glass houses shouldn't throw stones. Well, a good abstract interpretation would be along lines of, when you yourself have a fault, you shouldn't be unduly critical of others for having the same fault. That's essentially what it means. That you can get sort of halfway there answers sometimes, but that's a full response. A very concrete interpretation would be something like, well, the stones would probably break the glass, and the person is just unable to break out of, sorry to use the word break twice, but to break out of the literal meaning of the sentence to see that it might have, perceive that it might have some more abstract meaning. Don't count your chickens before they're hatched. Well, don't make plans based on future events that might not come to pass as you hope. Remember the old story of the woman carrying her eggs to the market in a basket on her head and thinking about all the money she was going to make and how she was going to buy fancy dresses, and she'd go flouncing around, and as she does that, she drops all the eggs and they're broken, and she has to, that's it. Concrete interpretation, well, they aren't chickens yet, just eggs. They didn't get it. Now, the MSE is not only important because you get information, direct information about cognitive functions and how well they did on story recall, how abstract their interpretations of proverbs were, and so forth and so on. You're also always observing. The informal MSE is also happening as you do the formal one. How do they approach the tasks? Some people are overconfident, and they're not doing well, but they're like, oh, I'm acing this, aren't I? You're like, ooh, well, that's not the best insight, is it? Some people, of course, experience a lot of anxiety, and the anxiety may be getting in their way. So they're not doing as well as you think they probably could. But at the same time, you also realize they probably don't do better because the anxiety is there in ordinary life just as sure as it is in your examination. Their kind of personality can come out too, especially when they're struggling a little bit. Well, I'm never any good at tests. Oh, that's a good way of defending against the failure. Just say, I'm never good at this. This is a really stupid test. Why do they have you do this? Okay, make note of that. They get flirtatious, they become really precise, and it goes, oh, well, let me see, it could be this, or they're telling you something like what the heart does, and you're getting all this stuff about the ventricles and the auricles and the arteries and the pulsing pattern of the blood, and you're like, yeah, all I needed to hear was it pumps blood, man. You don't say that, but you're kind of thinking it, but you're writing down everything they say. It's like, oh, a little bit obsessional, aren't they? And also when they have to kind of build an answer, especially on proverbs and also the judgment questions, thought disorder often is rendered evident here. So you're always watching and listening on several layers, several levels to what they're saying. Now, our last few minutes will mostly be about two short forms of the mental status examination that you ought to have heard of. One of these is called the mini mental state exam, the MMSE for short, introduced by Folstein and Folstein back in the 1970s as a kind of quick screening test for dementia. It's just 11 items long, and you get a point or 2 or 3 on each item. Maximum score you can get is a 30. If you score at least a 24, you're considered to be unimpaired. 23 is kind of equivocal with people in their 70s, 80s, but getting below that, there is some impairment present. So you'd be thinking, this might be a mild dementia, for example, if it was an older person. Below 17 or 17 and below is suggesting more severe impairment. This is really widely used, and there are probably 1,000 studies of it that have been conducted. However, there is a drawback here. It's quick and it's quite good, but some forms of impairment it doesn't really tap into because it's not comprehensive enough. So, for example, you'll often hear it criticized for a failure to identify cases of so-called frontotemporal dementia as opposed to dementia of the Alzheimer type. This is what a form might look like. I mean, there's an official one you can buy, but it's also some forms of it are now in the public domain, so you can just sort of find these things around. And, so 5 points for orientation, actually 10, right? You're giving the year, season, date, day, and month, state, county, town or city, hospital, and floor. You got 10 points already. 3 unrelated objects. Can you name them? Great. Repeat them till they know them. Say, remember those now? Then you do serial 7s up to 5 points. Ask them again for the 3 things, and so forth. More recently introduced is the Montreal Cognitive Assessment, or MoCA for short. Nasruddin et al. Up in Montreal, of course, introduced this early 2000s. Like the mini, the MMSE, it's a quick screening test for cognitive impairment. And maximum score again is 30. I think that's coincidental, but it happens to be the same score. On this one, usually there are different guidelines you'll see in different sources, but usually what you'll be told is if the score is at least 26, they're not impaired. So you're allowed to miss 2, 3, even 4 items here. Scores of 18 to 25 suggest mild impairment, and then so forth and so on. So you'll notice it goes deeper than the mini in that you have different levels of impairment that you can evaluate. There also are pieces of it that are not exactly like what's on the mini, like that thing where you're connecting dots, so to speak, at the beginning there is tapping into more of a frontal lobe sort of function. So it's more sensitive to mild cognitive impairment than the mini, goes pretty deep, and also is distinctly more sensitive to prefrontal lesions. So overall, we're getting ready to be done. What about the MSE? You do a thorough one, you've got a wealth of information before you. You have all the formal scores from the procedures, as well as your clinical observations of how they approached the tasks, how they dealt with the interpersonal situation, the challenges inherent in the situation, and so forth. But in practice, detailed, extensive MSEs are the exception rather than the rule. What you tend to have are much briefer assessments being performed. And even when it is a pretty thorough one, they're really, it's not as well standardized as one might like. There are a couple of standardized versions out there, like the Strub-Black mental status exam in neurology is at least semi-standardized, but mostly that's not there. So you're going more based on your clinical judgment, based on your experience and what you were taught on internship, residency, what have you. So most of the support for it really arises from tradition. It's been around a long time. There's a lot of accumulated wisdom here, probably also a few clunkers that we think are wisdom and aren't. It's also true as a limitation here that nowadays in the post-DSM-3 world, many of the standard psychiatric diagnoses can be made based solely on the interview, just asking about the symptoms, the diagnostic criteria in the DSM. You don't necessarily always need a detailed MSE to get there. So in practice, when it's used, many practitioners use a kind of a brief form, a handful of questions that they tend to ask everybody that in their experience tends to be enlightening. And at that point, we are actually done. And I'm going to say good day to you all, and we'll see you again sometime soon.